Okay, we're going to talk about eyes, ears, nose, and throat, and talk about the different diseases associated. With this, what we're going to do is come up with an assessment plan. What's the reason behind the pathophysiology, and get our field impression as we're dealing with the eyes, ears, nose, and throats and different type of injuries that are there. With this, we're going to come up with a differential diagnosis, but in order to do this, you need to have a good assessment of how the eyes, ears, nose, and that works, and how we can formulate a treatment with that. So in our initial introduction, again, we always talk with our anatomy and physiology. We're going to talk about how the head and neck contain all our organs that we're worried about. We're going to address some of the conditions with the head and the neck. And then, of course, the big focus is our ENT, or ears, eyes, nose, and throat. So we're going to start off with the eyes first. Obviously, eyes are our vision organ. Our main focus there is what they do is they bring in light and focus that onto the retina on the back of the eye. From there, that's where the eyes have their cones and rods and are able to interpret what they're seeing and formulate a picture that'll travel itself down the optic nerve, which I will have a good diagram for you later on in this presentation and show you all this anatomy that I'm going to talk about. So big focus of eye injuries and what they're doing, so we have to really understand what type of injuries and what's being involved, and based on that, that helps give us our differential diagnosis. So our external anatomy of the eye, obviously our eye sits in an eye socket, or they call the ocular orbit. That's got subcutaneous tissues that are around it, and that protects the eye, as well as it's got the muscular area on either sides, above and beside, that move the eye and allow it to look around in all the directions. Protecting the eye and everything within the socket, of course, we have our eyelids, and that's to be able to close and protect everything so nothing gets in there. Actually, you can lift your eyelids up and look back underneath where the eye is, and that eye can easily be popped out as well. So really trying to protect that area, as well as the ocular orbit area is easily fractured as well. And we'll talk about that as well, and how that'll affect the eye. So the other aspect we have from an external portion of the eye is going to be the eyelashes. Basically, these function as a couple different things. Usually there are sensory organs that are able to keep foreign substances out. As anything gets close, they're automatically going to blink. And then right at the surface of the eyelashes and the eyelids is where the glands are. And these are sebaceous type glands that'll secrete an oily substance, and this is what keeps the eyelids soft and pliable and able to go back and forth. They also have other secretion glands we'll talk about later, in which that'll form the hard surface or kind of crust at night too, when that area builds up, called the sand in the eyes, if you will. So other areas that we're going to look about is the conjunctiva. This is basically what covers and protects the exposed surface. This is where we have the lacrimal gland down, and it's where tears are coming out in the corners of each eye. There is also association with this through the nose, and their ducts go right down into the nasopharyngeal pathway as well. So that's an important aspect of where we go, because we have to have tear production, keeps the eyes moist, make sure that everything is able to operate in a function without drying out, which is definitely going to affect it. Our conjunctiva, which is basically that surface out there, has lots of blood vessels across there too. You can get what's called conjunctivitis in that area as well, and that can cause other problems, so which we're not going to get into at this point in time. Here's kind of a diagram of what we're going to see. This shows where our lacrimal glands are. These are kind of sebaceous glands that'll come out right by the eyelids. And then down before we have our papillae and where the duct is, and you can see how that goes down into the nasopharynx. And this will shoot tears through there, but it'll also secrete down into the nasopharynx. And so you get crying in the eyes, and you get that dripping and nasal secretions out your nasal passage, nasal drip, if you will. And those are all associated with each other, and that lacrimal gland will actually feed down into those tear ducts as well. So that's just kind of a overview of some of our external anatomy there. Now we're going to go into more the internal approach of what's there. And when we look at the eye is basically considered a globe, if you will. There's two main portions of it. We have our the posterior cavity, and then we have the anterior cavity. The anterior cavity is also divided up into two cavities as well. Starting with the posterior cavity, though, posterior cavity has the vitreous humor. It's a specialized, very thick liquid that's back in there. So as the light comes through, it's got our rods and cones that kind of go back there, and our retina is in the very back. That's where we focus. Whereas the anterior cavity, or the front cavity, has the aqueous humor. This is more of a clear fluid because this is where we want light to pass through. This keeps all the areas liquefied in that, but this is more of a clear surface. Still very vitreous, but not like the vitreous humor. Part of that area is around the pupils and the lens, and I'm going to show you a picture here in a little bit that is going to show you that anterior cavity. But that chamber has pretty much two areas, and what divides those chambers is really going to be your iris and your pupil. Divides that area up. Your lens is going to be in the posterior aspect of the anterior cavity, if you will, or that posterior chamber. And then your front chamber is going to be the main surface of your eye. And then that, again, the iris is going to be right in between. Now you're also going to see your musculature that's going to be focusing on both the lens and on the iris. And that's what's going to function to pull the lens to help focus it on what it goes, as well as the iris to allow light in. When we're looking at the layers, there's three layers, and we always talk about layers anytime we're dealing with any type of anatomy. Our innermost layer is going to be our retina. Our middle layer is a choroid, and the outer layer is called the sclera. And that sclera is basically what we call about the whites of the eyes. The cornea itself is going to be on the outer surface, and that's that transparent curve portion. It is part of the sclera, but that's where the light initially passes through as it heads through the iris and pupil into the lens, where the lens focuses it on the back of the retina. So that's going to be our main focus here. And as we look at this, we'll talk about the different layers themselves. So the choroid, which is the middle layer, obviously this is going to be our vascular layer. There's kind of a trending theme that you'll see when we talk about that middle layer, but that's going to be our vascular layer, and this is what's going to feed all the tissues and keep everything maintained. You also have the iris, which again is going to be the division, if you will, between the anterior chamber and the posterior chamber on that anterior aspect of the eye. This portion is, again, has some musculature around it. When we get to the slide on there, it'll show that. That's going to allow it to dilate and to shrink. With this, it's going to affect the pupillary size. This also is the colored portion, which color is basically done by genetics and how that comes out. When we start looking behind the pupil, that's where the lens is again, and it will focus and the muscles will pull it based on how the trajectory of the light is coming in and what we're looking for, distance or close, how far away it is, and as much as the light's coming in. And it's going to bend that lens to focus it and focus that light on the posterior aspect of the eye, which is the retina in the back. There it has the specialized areas to read that, and then the image is basically received, and then it's sent down through the optic nerve, and which was sent to the brain. Now, of course, the lens is also going to reverse that image, so it's actually inverted and reversed on the posterior aspect of the eye of what it sees, and then focus that up to the brain, and then the brain can interpret what it's looking at. On the back of the retina itself, it has two types of receptors, and I talked about the rods and the cones. That's an important concept to know, is that the rods and cones are in the retina, and they're the receptors that can basically interpret the light as it's hitting them. The rods basically do the dim light. There's no color with them, whereas the cones has the bright light and do perceive color. So those combination of the two is going to interpret what it's looking at. When they receive the light and that hits on those basically send a impulse, or basically a sensory input through the optic nerve, goes right to the brain, and then the brain can interpret it based on those nerve pathways that are sending it from both the rods and cones of what the image looks like, shape, and adds color. So this next one is going to be a anatomy of the eye, so we'll be able to take a look at that. And as you look at these, you can watch those down. You should have the same copy of this in your book to follow as well. And shows that that anterior portion of the eye is actually the smallest portion. It's that the vitreous humor is the main portion of the eyeball, and that retina is where it accepts everything. And the fovea centralis, you can see at the back, that's the main part where the body, the eye is going to be focusing when that lens gets that light. That's the main part where it's going to try and focus onto there. And then those sensory inputs throughout the entire retina are going to come down. So we'll talk about a lot of diseases that affect this, from our diabetes, glaucoma, retinal detachments, traumatic injuries, all sorts of things that are going to affect all these components of the eye. Different type of medical conditions that we're going to see with the exterior portion of the eye, as well as you can have a sty form. Basically what this is in the eyelid themselves, the oil glands will back up and causes the blockage, and where that does, it'll actually build up and form this little pustule, if you will. It's usually under the eye, can be very irritating, can actually scratch or cause some irritation on the eye. It also can be, relieved by relieving the blockages and warming that area up. So antibiotics are sometimes necessary on that, but that's a definite condition that you'll see as you lift the eyelids up. Can be very commonly found, but it is obviously easily taken care of as well. Some styes can actually be there and be permanent as well. The Chalzon is basically an inflammation or infection. This is, again, dealing with the glands in the eyelid itself, and the meibomian glands. This is what, again, lubricates the eyes. It's part of with our tear duct that comes in here. So you get those areas in the tarsal plate underneath the eyelid can cause infections. I'm not so much worried that you're going to know this one, and I'm not going to have any test questions on this, but it's basically very similar. It's anytime you get a blockage of the glands, if you either treat with antibiotics, antibiotic drops work fantastic, and they can relieve this and get this removed and taken care of. Next thing I'm going to talk about is conjunctivitis. And then conjunctivitis is basically an infection of that outer layer right around the eye. This can happen a couple different ways. You can get a bacterial infection, pink eye. You can be just right around the cornea itself. It can be pretty much all around. The most common way to treat this is going to be antibiotic drops. And these placed in the eye and take care of things. But you see someone with the pink eye. Usually affects one side more than other, mostly commonly associated with fecal matter getting up there into the eye as well. So this is also very contagious and can be passed on through touch. So one thing just to be aware of if you see that, and I'm going to show you a picture of that in a minute that will basically show a child that does have pink eye and what it looks like. And this can also, when you get that conjunctivitis, it can also back up some of the lacrimal glands, and you'll see those changes as well here. You can see that there's excessive amount of production on the areas. It's trying to get that area, anytime there's infection, it brings swelling into the area, and the lacrimal glands will go. As this comes, it'll build up, and actually it'll harden almost like little scabs around the area and build up in the eye. Usually the only thing it is to do is the antibiotics to get rid of that initial infection around the conjunctiva, and once that clears, then the normal tear production comes out and clears right out. The other aspect you can have is you can also have, besides a bacterial infection, you can get a viral infection. Very similar. Again, the difference between a bacterial and a viral infection, the viral infection is something you have to have run its course. It's not something that can be treated by the antibiotics. You can actually use the antibiotic drops on this. It won't help, but it'll basically keep from the area getting a bacterial infection on top of the viral infection. But mostly with any viruses, you just got to let them treat its course, unfortunately. Other types of infections and inflammations can be from allergic reaction. These you're going to get high exposures to. We get around here definitely in the springs and summers with our pollens that build up. and it's going to cause a very similar aspect to it. Not so much the pink eye, but you get the redness and swelling in there. With these, most of the time, just oral antihistamines will take care of the case, Claritin and such. But sometimes they will have to have drops in there to perfect it. There's also injections and other things that will help prevent this. So, but is very common with the eyes and something you're going to see and people be irritated with. Pterygium is basically it's where you'll get a wedge growth in the conjunctiva. This area, and I don't believe I've got a picture of it to show you, unfortunately, but when we look at it, it will be a little wedge shaped in there. Exposure on this, I'm not going to have you anything know more than that, but it's a conjunctival condition, a little growth in there. Besides that, I'm not making you responsible for anything else on that. When we're dealing with the iritis, it's basically kind of what it sounds like. Iritis is basically it's swelling, irritation of the iris area, or we talked about the middle portion of the eye. Usually we'll get some inflammation around the area. This can affect the posterior chamber as well, around the back part of the choroid, or they call choroiditis. Again, that's the central portion just underneath the retina. This can affect one eye, both eyes. Again, I'm not too worried about this. This is not a very common thing, not something that we're going to see so much. So not too worried about, again, that aspect either for you. Talked about blurred vision and that, so that's going to be there. Other aspect that we could be dealing with, though, is herpes simplex virus, and there's different herpes simplex that can go through, but one of them involves keratitis, and again, keratin is what we see in the skin. It helps build those up, but it's in pretty much all our layers there, and so our corneas are basically built with keratin layers, and it's almost like skin tissue that's built up on itself. And so the virus themselves, if you get a herpes virus in there, that's definitely going to affect it. So when that cornea, again, which is the clear surface where it bends the light through, gets affected there, that's going to cause changes or reaction that stops allowing light to go through. And that's where you talk about corneal blindness, where you could actually have to have a corneal transplant to remove that to allow the light in, because it basically changes with the keratin in there, hardens up and blocks any light from getting through, so they're unable to focus that on the back of the retina. These are associated with a lot of different things, but it is something that if someone's had a history of different types of herpes, they can definitely get this, and they're very susceptible for this as well. Herpes zoster, which is also converted as the shingles. These can affect the eyes. Anyone who's had chickenpox, which hopefully we all have had it, or at least have had the antibiotic on there. And once you've had the chickenpox, you are likely or possible to get shingles later on in life, after middle ages, towards older. This is another thing that affects the nerves, but it can actually get into the trigeminal nerve, and then that's how it'll get into the eye itself. So with that, you can get lesions, ulcerations, and it definitely is going to affect how the eye moves, as well as the pain that's going to be associated with it. Corneal ulcers are going to be another area that can happen, and basically these are infections that come through and they break down the layers of the cornea. So as you get that ulceration through there, it'll allow too much light in there. It can allow the aqueous humor to get out. You can allow infections down up inside. Once it gets down inside there, then the only way to go through is being treated. And usually, again, this is probably something we're not going to see. It's always potential going through. This is going to be more for an ophthalmologist, and that's going to be the important aspect. Another condition that we will see is cellulitis. Cellulitis affects the entire body, but as it affects to the eye, this is a swelling of the soft tissue around the eye itself. This can be a life-threatening condition as far as the back pressure, but usually it's just involving the site itself. It can damage the eye. Usually this is a very reversible condition. The swelling comes around the entire eye itself, but does not affect the eye. It'll actually cause the area to close. There's varying degrees of this. Usually the main treatment for this I'll get into is going to be antibiotics, and that treating the cellulitis depending on whether it's a viral or a bacterial. So in this next picture, this is kind of a moderate swelling of the eye, and you can see that it's involved all around the eye and the soft tissue. There's even some upper lid involvement on there. Other ones can be less involved, others can be even more severe than this. Big air risk for this is bacteria is the normal one. You can get conjunctivitis, blurred vision. Obviously the tears aren't producing. Usual treatment with this, you're going to get IV antibiotics. You can also do some oral antibiotics with this, but because they want to watch the intraocular pressure that's associated and make sure it doesn't damage any of the musculature or the eye itself, this can be a very critical condition that we need to get treated, and patients will be monitored into the hospital. So the other conditions we'll see with this side effects: fever, headache. Obviously we're going to get the edema around there, runny nose, generally going to feel weak. Anytime that we have any type of infection, the body's going to feel that general malaise anyway. But we want to make sure that that eye is watched, that pressure doesn't actually pop the eye out, and other factors can happen as well. Once this area does cause extreme swelling, some of the things that can happen is it can actually cause that swelling to push behind the eye itself and cause that eye to pop out or push out. It's going to be very painful to the eye, causing that pressure there. And the main treatment obviously is get that inflammation down. Sometimes this will go to an extreme aspect of having to surgically go in and drain the periorbital access area. If this gets an extreme amount of swelling, that's going to be a huge priority. It can actually even get enough pressure to actually break some of the eye orbit and the eye socket from so much pressure that can be built up in there. So this is a true medical emergency and needs to be treated in the hospital. Another condition you will potentially see is called hyphemia. Hyphemia is when we get a collection of blood that's actually in the anterior chamber of the eye itself. Usually this is a result of some type of trauma. I'm going to show you a picture and show you some of that area, but it can be non-traumatic as well. Big indications, and we'll talk about this in a hematology lecture later, but it is sickle cell disease, diabetes, different tumors of the eye can actually cause a break in the blood vessel, and the chamber right in front of the iris will actually fill up with some blood. This can, if not taken care of, can be threatening to vision and cause blindness. A lot of the times this can be simply drained, but be taken care of by an ophthalmologist. When we take a look at this picture here on the next slide, you'll see that there is a small collection of blood that's actually building up in that anterior chamber right up next to the cornea. And again, that can be drained. Another condition is called glaucoma. This we're going to see frequently in the elderly population, can be associated with diabetes, is going to be a big thing to it, as well as it can happen from other conditions I'll get into later. But one of the things we're watching is the glaucoma causes increased intraocular pressure, and that's what can cause blindness and severe nerve damage to the optic nerve. The other thing that it'll do is, because of that pressure there, it'll actually block any flow of the aqueous humor from the anterior chamber, and that constant circulation and flow, the body is always in that period of homeostasis, and by blocking that, that's also going to cause some damage to the anterior chamber of the eye as well. Here's a slight picture just showing that this can be done with different tests. Again, probably something we won't see so much in the field, be more of an ophthalmologist. Different things that can happen there. Again, we talked about the blockage of the aqueous humor. This can cause an increase in that intraocular pressure. And anytime we get some pressure, and I'm going to talk about that in another slide down the road here as well, anytime we get that pressure back on the main portion where we have the optic nerve, that can damage that and we can lose total vision. So again, a medical emergency with this. That's why it's tested quite frequently with that little puff of air going into your eye if you've ever done that at an ophthalmologist. Now, as we look at this, there's two types of glaucoma that we'll be dealing with. There's going to be a angle closure, and with that we have an open angle glaucoma, and as well as we have what's called a angle closure or a closed angle glaucoma. The difference between this is an open angle, we're having a problem with the drainage. It's basically like a clogged drain. Fluid is draining, but it's draining very slowly, so it can back up and build pressure. Whereas a closed angle will actually close that drainage from the aqueous humor. It will back up, and so there's not that constant influx or flow. That will increase the pressure dramatically, be a rapid increase, and will cause extreme pain. Those acute ones were build up. Those are definitely going to be ones that need to be drained and need a surgery immediately, where the closed angle can sometimes be fixed other routes. Again, not something we're going to be seeing or necessarily treating in the field. Cataracts is another condition we're going to come off, where we get a clouding of the lens of the eye. You're probably going to see this, but that will not necessarily be our chief complaint. This is going to be associated with a combination of things. Usually it's associated with aging and breakdown of the proteins. But with our diabetic patients, those who've had exposure injuries and that is going to be very common to see. With cataracts, we're going to see several different things. Basically what it's doing is, because it's over the around the anterior chamber itself, we're going to be able to decrease the vision. It decreases our light that can come in. It'll be fuzzy. We won't be able to focus it, so we're really not going to be able to see it effectively. Main treatment, this is going to be surgical, and there's a lot of laser procedures they can do to actually break down that glaucoma around the anterior portion, around the cornea, and even down by the iris and pupil where the area can build up itself. They can actually come in and pinpoint those spots and break up the cataracts. I'm going to show you a picture here, and that'll as well give you an idea of what you're seeing. But again, this is going to be something that we're not necessarily going to be called for as a primary condition, but with our elderly diabetic patients, this is something we'll probably see fairly frequently. Surgery done by the ophthalmologist, and they can use a laser and actually break up that cataract effect. Optic neuritis. Basically, this is going to be inflammation around the nerve, the optic nerve itself. A lot of the times this is going to be an autoimmune disease where the body is fighting back against itself. It can happen from infections, drug toxicity, MS. Usually anytime we get this, a neuritis is a temporary injury. We can get temporary loss of vision, can happen in one eye, usually is what's going to be affected, can be in most eyes. This can be associated with pain on the nerve. It can affect the different visions, whether how we see color, how we see light, lots of different aspects of how it's going to react. It depends on how much of the nerve is involved, where the nerve is involved, and where the pressure is coming from, that inflammation. The biggest thing that we'll usually do from this is it's going to be treated with steroids to bring down that inflammation. Again, something we may be called for extreme pain. As of what we're going to do for it, it's really nothing we're going to treat so much, but it'll be something that's going to be treated by, again, an ophthalmologist in the hospital. Another condition with papilledema that you're going to see is that increased intraocular pressure, and that's going to put pressure back on the optic disc, is where basically the rods and cones formulate the vision back and it travels down the optic nerve. This can happen from all different type of things. We talked about previously with blockage of the aqueous canal that can cause intraocular pressure. This can happen with infections, lots of different things. The retinal artery can actually get an occlusion or block on the artery that supplies blood to the optic nerve. And with that, you can get all or part of that complete vision. If it's blocked for too long a time, the actually portion of the optic nerve can die and can be a permanent blindness. Usually with this, there's going to be several different things. One's trying to remove that blockage by manipulation of the eye, or it's going to be as well as antibiotics. Another aspect could be actually the vein can be occluded as well. Same thing where we're not getting that drainage coming there. This is going to be very common with diabetics, obviously hypertensives, There can be atherosclerosis with this, a lot of other conditions that are going to be associated and can actually cause the same thing where we can get permanent damage. You can see a lot of the times that blurry vision on there. Majority of the time these aren't treated because we get that blockage and that occluded the vein will eventually open up and it clears without any incident. Retinal detachment is a big thing that we're going to see mostly with our diabetic patients. Diabetics get a lot of issues because we're dealing with the small vessels to the eye. You get separation of the retina from the back, and what's going to happen is a lot of different things. The first initial cases, you're going to see those floaters across the eye that are going to affect the vision there. But once you see this, you get shadows, blindness. If we start getting partner rush attack, the only way we can check it is with an otoscope. They can surgically try to reattach that, but with some diabetics, because of the damage to the small nerves, there's really nothing that can be done at that period of time, and that can lead to total blindness. Now, as we're looking into the ears, obviously this is our organs that we're going to basically be translating sound waves from the environment and process that into the nerves into the brain and interpret exactly what we're hearing. This also plays a big part of equilibrium and balance as we talk about our inner ear. So again, starting with the anatomy physiology, we have the external ear called the pinna. Basically what this does is this collects and directs the sound waves so it goes right into the auditory canal. Therefore, it will go into the tympanic membrane and then start into the middle and inner ear, and that's where we translate our sound. So again, the pinna is just our collection point. As you can see from this diagram, this shows from the external ear, showing from our auditory canal and where it comes down right into our tympanic membrane. Now I'll talk about that auditory canal later, but that's basically where we get earwax production. We can get a lot of foreign body obstructions and comes down to our tympanic membrane. Tympanic membrane is going to take the sound waves and coordinate that into the middle ear, as you can see from this diagram. So we can get a lot of ear injuries, and I'll talk about that as well. Inside you can see our anatomy of where we have our inner ear with our malleus, incus, and stapes, and then going into the inner ear where we have our vestibule, and this is our canals and interior, and that's what deals with our balance and finally interprets the sound waves and translate that into the nerves going into the brain. The middle ear, as we talked about, are three small bones joined together, malleus, incus, and stapes. Those are going to be important to know for the test. You can be asked for anatomy on there, but again, we're dealing external ear. Middle ear is our bones, malleus, incus, and stapes. The tympanic membrane is just that border between the outer ear and middle ear. So the tympanic cavity is basically what that's called, and the eustachian tube, or the auditory tube, as I refer to. This is where we get that equalization as the tympanic membrane moves. When we swallow, we release that exterior pressure in the inner ear. Great for diving and also for flying. The inner ear, we have that separated by the bones where it comes over, and that goes into our canal. This is basically in our vestibule area is where we have all our hair follicles, if you will, and as that goes over those follicles, that's what allows us to interpret the sound waves and convert those waves into what we're hearing. Those are all filled with fluid. And those fluid, and you'll see, and I'll show you a picture of it, the chambers are actually hitting all different planes, and that's what affects our balance. So we can get our proprioception from those, and we'll understand where we are. It's almost like a gyroscope, if you will. And those fluid-filled chambers do two functions. One, gives us our balance, but two, inside those are all these, for lack of a better name, hair follicles, and they get knocked down as the waves come through those, and as they get pressure and pushed across with those sound waves, that's what's going to interpret what we're actually hearing, background sounds from up close sounds. Very complicated process. Again, I'm not going to go too specifics into that. So our portions of the inner ear, we have our vestibule, we have our semicircular canals, and then we have the cochlea. The vestibule itself, again, this is our membranous sacs. This is where our body senses where we are position-wise and going forward, backwards, up and down, and gives us that sensation. The semicircular canals is what's going to affect rotation of the head, what position we are, where's our proprioception, and side to side. And our cochlea, the spiral-shaped structure in there, we'll see a picture, is where we get the receptors for hearing that to hearing. That's where all our hair follicles, if you will, are going to be in, and that's going to focus majority of those sound waves into that portion, and that's where that will be translated in the nerves going up to the brain to focus on what the sound waves brought in and what they are. So with this picture, you can see those positions with the semicircular canals on top. You can see the vestibular cochlear nerve that basically comes from both the vestibule and the cochlea, and that translates that information out, where the semicircular canals, those are really going to be our proprioception position-wise. You can see there in each of the different planes. Big medical condition we're going to have, one is foreign body, and that's going to be kids sticking stuff in their ear. We can get bugs, insects in. We can get bleeding from penetrating trauma that are in there, and those can usually be removed very simply. Again, if you talk to most doctors, they say don't put Q-tips in there, but you can do some flushes, clear that out. If you get sent into an ENT, they actually have small equipment that can go in and remove specifically for removing earwax. There's candles that can be done that pull out. There's so many different things that can be done. Flushes, otic drops, a lot of things to clear that out. This next picture, though, I'm going to show you is different things can be found into the ear, foreign bodies. Insects can climb in there, fly into your ear. If they get too far down in, they're really hard to remove. Different ways it can be is you can actually try and go a small pair of forceps or going in to see a physician to remove those. Other things they say, if you can't or you're in a position out camping in a spot where you're away from any of those, you can actually put mineral oil air and in the ear, and basically what you're doing is you're clogging that ear and filling it up, so you're suffocating anything that's climbed in there, especially insects, bugs, or such. And then once it dies, you're eventually going to try and flush and get that out. Those are in the severe cases when you're unable to get to a doctor or someone can pull in. This is actually a picture of a lady who had an irritating and buzzing in her ear, and through the otoscope, as they're looking in there, actually found a spider down by her tympanic membrane that had climbed in. When we're dealing with the inner ear as well, we can have a lot of different things. The serum is basically the wax. Wax is there designed to trap any dust, debris, smoke, other things come down there. Those can build excessive aspects. That can block sound. Too much buildup, again, you have to remove those. Other things that you can get with this is tinnitus, which is the ring in the ear. And again, flushing those out using the candle actually will pull and draw wax out as well. Inner ear infections can come from a lot of different things. It's mostly with the kids, but you can get external ear. They called otitis externa, or swimmer's ear. Gets that inflammation and irritation around the external portion of the canal. This is pretty common, and they have drops, otic drops, that are usually put in, and that takes care of that pretty easily. For severe cases with inflammation, you can be put on to ibuprofens, antibiotics, just to get rid of those symptoms. Long-term tinnitus can happen with any type of infections on there, but usually are resolved and pretty easily taken care of. Again, probably something we're not going to be treating. And this talks about some of those treatments there. So other areas for that inner ear is we can get the otitis media, which is, again, more commonly in children, blocking of that auditory canal or the eustachian tube, and that puts increased pressure down there. Also causes flueness, other issues as well with nausea and vomiting. These can be chronic infections that can persist for long periods of time. Usually antibiotics are in there, and with a lot of kids, what's required is actually to put tubes in the ear to decompress that tympanic area. That'll be removed later on in life. If you do get damage to the tympanic membrane itself, it can be perforated. These usually will heal on their own. Ways they can get that is trauma, foreign bodies. Biggest thing is actually infection that can come on. These are extremely painful. It can get anywhere from headache, can be pus, buzzing noises in there, but usually a break in the tympanic membranes can be very painful. Also happens at concert goers. Extreme amount of sound waves in there can actually cause it to break up. Usually these resolve on our own. They will heal up in a majority of times. A lot of times, like I said, because of the pain and chance for infection, they'll need to be treated with antibiotics and pain medication. Other than that, they heal usually pretty well. Some will require surgery. Here's actually a break in the tympanic membrane. A close-up view, as you can see the nice clear structure above and down below where it's just been popped and broken. This has also happened, like I said, can happen in explosion injuries. We'll talk about blast injuries another time. Another condition we have is called mastoiditis, or basically where the mastoid bone is, or the process, you can get an infection down there. This can be associated with a lot of different things. Ear pain, can be drainage from the area. Usual treatment for this with anything is going to be antibiotics. Most common with this, again, we may notice it there. Labyrinthitis, basically in the labyrinth portion of the inner ear, there's swelling and irritation. This can be associated with a middle ear or upper respiratory infection that will actually transfer up there. Anytime we get an infection in the labyrinth, we can cause vertigo, dizziness, loss of balance because we're dealing with our proprioception of where we are, and it's basically treated as need be. Meniere's disease is an inner infection, also affects balance and hearing. Swelling in the labyrinth, again, it can come on very quickly, be like vertigo. There's really no known cure for this, and treatment is basically going to be taken care of. Now, as we move on to the nose, anatomy, physiology, obviously this is where we're smelling, but we're also doing warming and humidification of the air that's coming in. Again, we have our olfactory nerve that comes down, so we get our sense of smell. Brain processes the signals, and then this is also associated with smell, and then taste, which is on the taste buds and the tongue, are very closely associated because that gives us our sense of taste based on smell as well. When we take a look at the anatomy in the picture, you can see the chambers. You're familiar with the nares coming down through each nostril going up, and where the lacrimal gland is, you see the hard palate going into the soft palate, breaking the nasopharynx up from the oropharynx area down into the pharynx. So just brief anatomy, be familiar with this design. I'm not so more worried about the foramen, but just again, just a general impression of this. Once we're talking about the anatomy, again, very highly vascular. Kissaball's plexus is basically a artery plexus, and 90% of our nosebleeds are involved with these. These are inside the nares that come down. We also have our sinuses inside. These are air-filled cavities. These can be filled with mucous membranes. They can be extremely swollen. They can cause very painful. We get the sinus headaches and that from pressure that's built up in those right along our ethmoid process. So when we take a look at this next picture, this is going to show where they are. So our upper areas up in the femoral areas, their ethmoid and sphenoid areas right across the nose, these can all get extremely swollen and painful. Can build up with mucus, can build up with fluid. Normally these are just open air on a normal basis. Again, treatment for most of this stuff is going to be very simple and straightforward as far as antihistamines, antibiotics to clear up those areas and take the pressure off there. So as we continue talking about the nose, biggest thing that we're going to see common is nosebleeds. Right now, this time of year, we're getting an extreme amount of those because of the dry conditions. Especially if anyone has high blood pressure, can pop those in. Minor irritation. Again, the Kisselbox plexics, I'd just be familiar with Kisselbox, is where most of the blood comes through. This can bleed posteriorly back in the cavity. A lot of the problem basically is just going to getting that bleeding to stop. That's going to be your major function. Now, we've got several things that we can do for this. Direct pressure, having them lean forward to get the blood coming up, and we can actually, they don't talk about putting in, but we can put nose clots up inside the nose to stop that. A couple other things that you can do very easily for nosebleeds is you can actually take a rolled piece of gauze and put it up under the upper lip. It pinches the nerve right at the base of the nose. That putting pressure on that will also help stop with bleeding. Again, initially you're going to want to put pressure on there, pinching it. You can put what they call the nasal tampons or outside the nose box, the nose packs up in there, especially for wrestling. That's a good place to start. We also will talk about other medications that we can use, basically using our Afrin sprays up in there. The main purpose for Afrin is for sinusitis and it is to get rid of swelling and cause nasoconstriction of the arteries. That's what it'll do up in here, and it'll actually open up our arterial pathways, constrict down on the arteries, and stop that bleeding. A couple puffs up into each nose can work very effectively, but talk to Gary about what you do with someone who's got a known headache and high blood pressure about that. Another condition that we're going to get is going to be mostly common with kids, but we will see this in other aspects, is foreign bodies. So kids are going to stick things up their nose very easily. And there'll be all sorts of aspects of trying to get those out. Again, a lot of times we can try and remove, sometimes because we don't want to cause any other injuries or damage, we'll actually transport in the hospital and have them removed in the hospital. That's usually the best thing, unless you can physically see it, grasp it, even with the McGills or something pull out. A lot of times we're just going to leave it in place, transport them to the hospital, and have them remove it at that aspect, because some of the foreign bodies need to have x-rays to see exactly where they are and need to be surgically removed in some cases, or anesthetize patient of where it is, and you never know if it extended back in the ethmoid bone or such. Extra credit to anyone who knows this character's name. Obviously, I don't want the actor's name, I want the character's name. If you got that, fantastic. Rhinitis basically is inflammation of the nose, postnasal drip, continual upper respiratory infections. Infants see this a lot. Big thing is suction, corticosteroids, antihistamines. That'll protect or treat this, and common thing that we're going to see. Not much as far as treatment on there. Big thing is when they do get these headaches, pressure, pain, antibiotics, Benadryl, corticosteroids is going to relieve that, and that's going to be the main basis of what we're going to do, is get them into the hospital or get them to their doctor to treat for those conditions. Now, as we look at the throat, again, this is going to be our opening to our oral cavity, as well as our esophagus. We're going to get our gas exchange here, of course. Our important aspect from this is making sure our airway is open, tongue isn't laying back on there, and this is where we're going to get in for our intubations, of course. So, as we know, we've got our lips, we got the hard palate and soft palate, we have our tongue, our pharynx in the back, and our uvulars, all our structures, and you need to be aware of those. As we look in the picture, you can identify each of those here. Again, I do want you to know what we're looking at and know what the anatomy is coming in as we lift the tongue up, knowing where the uvula is, and then coming down as we're going towards the epiglottis as we get in the back and the pharynx. Here's a picture of the tongue, just kind of shows where the taste buds are, which cranial nerve is affected, and our different forms of taste on the portion of the tongue, how the anterior to the posterior goes from sweet to bitter. With the throat, our anatomy that we're looking at is tonsils and adenoids, which may or may not be removed on kids. Obviously, we know our teeth is, and we're protecting those. We have our salivary glands all around, our esophagus, and then the larynx are two main structures that we're going to be dealing with as far as maintaining and protecting airway, and especially with our intubations. Excuse me. Pharyngitis or tonsillitis, basically this is going to be swelling of the oral pharynx area and the pharynx, as well as in the tonsils, kind of back of the throat as we look into this. This is not necessarily something we're going to be called for specifically. They'll be going to see their physician about this, but we may see this and be aware. Usually an infection process, either viral or bacterial, going to be very painful and swollen. Lots of over-the-counter medications that can be done, as well as antibiotics done by their physician. Viral infections, really not much they can do except for symptomatic treatment, trying to numb the area up with like the chloroseptic sprays and other topical pain analgesics will help with that. The bacterial infections are really going to need the antibiotics, depending on which kind of bacteria. So here's a picture of tonsillitis, and you can see how swollen those are in the back, and just be aware of that for as far as our anatomy. Other condition is going to be oral candidiasis or thrush. This is a fungal infection in the mouth, highly seen in infants, diabetics, AIDS patients, or anyone with HIV, any immunosuppressant patients, patients on chemo, highly susceptible to this. The body normally can fight these things off, but fungal infections are prominent. Hands, fingernails, toenails, and mouth. Anywhere that you can get a fungal infection is going to be greatly affected anytime someone's on immunosuppressants or they're depressed. Here's just a slight version of one. It can come in all mild to severe. This is be a moderate case. Usually on there, it's basically using antifungal agents, either orally and topically. We can actually be using tongue scrapers to remove there, but until you treat the antifungal agent, that's the only thing that's actually going to remove this. Hard part is, again, the body can normally fight off these type of infections, but because their immune system is depressed, not acting in a normal way, this is going to be a highly susceptible to these fungal infections. One of the first things you do when you're talking to someone is you will see in their mouth, if you're not taking a look at their hands or their toenails, and if you see an oral thrush on this, you know that they're immunosuppressed, and that's going to help lead you towards your differential diagnoses of potentially other things going down because their immune system is not working as well for some probably systemic disease. Peritonsillar abscesses, so we showed you the tonsils. Now you can have abscesses. Peri means around, so any type of inflammation or abscesses that are around the tonsils and area. These are usually filled with pus. They are very easily removed. A lot of these times they are drained. Patient is put under anesthetics to knock out their gag reflex, conscious sedation, and then they're able to inject, numb, and either drain these abscesses, sometimes cut into the abscesses, sometimes surgically remove, depending on how bad they are and how much they are affecting the airway. Then we'll get into the next portion of this, which is when they get swollen and do block that airway, they can get so big and hold on for so long and actually swell even more that we're unable to intubate. Patient is going to have the definite signs of an infection process, the chills, difficulty breathing, swallowing, drooling. They're not going to be able to open up their mouth very easy. It's going to be very sore and tender. And as you get back in there, and if you even touch the area, you're going to cause even more inflammation and swelling. So it makes it very difficult. A case like this, when someone is swelling, it would be that consideration of preparing for plan A, B, and C. Because if this patient swells completely and doesn't have their airway and you can't get in there, you will be looking potentially at a crike on a patient like this, just because you can't see the anatomy, and you'd be searching with a bougie tube, and as you do that more, you're going to have even more problems of irritation and swelling because of just that treatment. Antibiotics and draining, like I said, are going to be the big thing, but what we're going to be most worried about with this is going to be maintaining their pain level and being ready to do sedation on them, so that we can intubate if need be, or we're going to be able to just take their airway in general and have to go potentially with a crike if we're unable to see into the anatomy, because a king airway is not going to fit in the severe cases. So big thing to watch, and it'll be important there. So as we move on to the next slide, Ludwig's angina. Basically what we're here is this is an oral bacterial inflammation. It's on the floor of the mouth, so it's actually underneath the tongue. This is a true medical emergency. You may see people and it just appears that they have almost like a double chin is what the impression is. But what will happen is from the lower gum down underneath the tongue, and it'll drop, it will swell. And as that swell, think about someone who has an anterior airway. Well, where is that? Well, it's basically right underneath the tongue. That's why this can be a very life-threatening injury, because you can completely lose their airway and any access to this. I'm going to show you a picture of basically what this looks like on a patient. I'm going to show two side-by-side pictures of this, but this may look like someone who just has a double chin, but the swelling comes down, puts pressure. You're not going to be able to see the anatomy. As you can see right here, that swelling can push right up against that airway and you can lose it. So this would be someone where you're looking for a crike. Biggest thing when we see this, they're going to have difficulty breathing because they're going to become hypoxic. They can see confusion or mental changes. Anytime we get inflammation, and they're going to be everywhere from weak, fatigued, tired. We can see drooling and definitely pain with this, because that swelling in the area, especially on the lymph nodes and along the nerves in there, is going to be a very painful process. So something to be aware of and be familiar. So I wanted to show you a picture of that just so you know what you're looking for, and it's not just someone with a double chin, but you see that swelling in there. Be thinking, if I lose their airway, I'm probably not going to be able to intubate, or it's going to be difficult because of my anatomy inside with that swelling pushing up, because it's not only there, but it swells right back around the trachea. Dentalgia or dental abscesses. This is a result of several different things. Usually it's lack of care in there from not flossing the teeth. These can build up. I'm going to show you a picture of swelling. These are usually along the gum lines or around the teeth. They're non-threatening. Again, we're usually probably not going to see any reports for us on a call like this, but I want you to just be aware of those. They are, anytime we get these infections in there, that infection can spread to other parts of the body, and that swelling in there can affect our anatomy and what we're dealing with in the mouth. So I just want you to be aware of that as well. So as we look into this picture here, you can see the gum line, and you can actually see that swelling right up above the teeth. And this is, again, just a very mild one, but they can be very severe through here as well. With these cases, usually what we're looking at is we're looking at some type of antibiotic that needs to be done. This is going to be something they're going to be often seeing their dentist and being treated for. We're really not going to see this, and I'm not too worried about that level for you guys of what your knowledge is, just to be aware of that. Foreign bodies, we can have a lot of different foreign bodies. Again, dealing mostly with kids that are going to be lodged down in the throat, obstructing airways. So kids swallow a ton of different things. Just be aware of what's there and how we're going to get those out, observing, looking in. Sometimes McGill's forceps, we're not doing blind sweeps, of course. Epiglottitis, this is going to be an inflammation of the epiglottis. With this, you see the drooling, the stridor, the hoarseness. This is going to be something with corticosteroids, antibiotics for treatment on there, but this is a true medical emergency, and you have to be careful because any touching or pressure down there is going to cause problems. Here's a picture which just shows kind of that epiglottis just completely swollen, and the vocal cords are down below in there. So think of how difficult that is going to be to intubate a patient with that as it continues to swell. Any laryngitis, tracheitis that we're going to talk about, so swelling first in the laryngeal, in the larynx portion, and then down into the trachea can be swollen as well. This is definitely going to affect us, especially if we have to intubate the patient. This can come from bacterial infections, allergic reactions, chemical exposures. Obviously with this, they're going to have the standard problems as far as fever, infection, cough, everything from there. As that area swells, that area can fill up with mucus, so they're going to become hypoxic. They can start getting that stridorous respiration because of that block in there, so just be aware of those things as potential problems as well. As far as the TMJ joint, this can lead to a lot of different things, but the temporomandial joint, especially with chewing and that, it's interesting. Actually, a person with a limb length discrepancy can get a TMJ, so you can actually fix by fixing a limb length discrepancy their TMJ. Anyways, so going back into summary on this, want you to be very familiar again with the anatomy. If you understand these processes, you can come up with the right questions to get a differential diagnosis and really understand the ENT aspect. Majority of this stuff we are not going to be treating, but I want you again know what the normal, what the abnormalities that can come in his, and so you be familiar with them and what to do in case we have a